So welcome everyone to the fifth and final webinar in this webinar series, exploring leading health organizations' efforts to assess and address social needs that impact health. This webinar features an update from Contra Costa Health Services. We'll be sharing how they have measured and evaluate their return on investment for their social needs initiatives. My name is Marie Hubbard, and I'm Program Manager for the California Improvement Network, also known as CIN. CIN is a network of healthcare leaders focused on innovation. The network is a program funded by the California Healthcare Foundation, and it's administered by Health Force Center at UCSF. A few pieces of logistical information before we get started. Everybody is on mute and will remain on mute for the rest of this hour. If you have any questions, please use either the chat function or the Q&A function located at the bottom panel of your screen. This webinar will be recorded. We will plan to share the recording widely among the CIN network, but also please feel free to share it with your networks as well. Now I will introduce our speakers. As facilitator, we have April Watson. She's a Director of Practice Transformation at California Quality Collaborative and is also one of CIN's managing partners. And our presenters are Elizabeth Hernandez, a health planner and evaluator at Community Connect, and Daniel Brown, who is a data scientist at Contra Costa Health Services. So I will now pass it off to you, April, to get us started.
Great. Thanks so much, Marie. And thanks to everyone who's joining us on this webinar. Yes, I'm really excited to welcome back Beth and Dan, who, if you joined the webinar, I think it was late last year, they talked about their program for social determinants of health and how they're thinking about return on investment. And so we're really happy that they accepted our invitation to come back and talk a little bit more deeply about data and how they're using data for program design in Contra Costa County. So I'm not going to really say any more, but I'll jump in with some questions along the way. So Beth and Dan, I'll turn it over to you.
All right, thanks April, and thanks everyone for attending today. So yeah, our talk is titled Integrating Data into Program Design for Addressing the Social Determinants of Health, and we're going to talk a bit about our program and the different ways in which we're using data to improve our program in a number of different directions. So a little bit about Contra Costa County. We're a large county health system. One of our, kind of, I think, greatest assets is that we were integrated from a IT perspective kind of well before this program started. So our health plan and our hospitals and clinics are all kind of serviced by the same IT department that allows us to kind of share data across a number of different departments easier than I think other similarly positioned health systems have been able to do. As part of our program, we were able to bring our behavioral health system into our Epic environment, our EHR environment, but we already had a number of our different programs integrated in such a way. So we have a list here of a number of the different parts of the health system that are all have their data flows accessible to us as an IT department.
So one of the programs that our health system operates is called Whole Person Care, and this is one of the ways in which the health system is addressing social determinants of health. Whole Person Care is an 1115 Medicaid waiver program in California that was part of the Medi-Cal 2020 waiver project. And its point was really to look at patients who are medically complex, high utilizers of multiple systems, and to look at ways in which services can be provided, ways in which care can be better coordinated, and technology can be used to address this population. 25 different counties in California received funding, and it was done through a federal match. So counties put up $1.5 billion, and then the federal government matched that with another $1.5 billion. And each pilot is operated very differently. So every pilot can choose a target population and address a set of services that they're going to do to look at specifically reducing utilization in the emergency room and inpatient units. Our project in Contra Costa is internally branded called Community Connect, and our pilot is a $200 million pilot over 5 years, and we provide services to over 12,700 patients at any given time. So over the course of the pilot, the 5 years, we'll be serving over 42,000 patients. Patients are enrolled for 12 years of case management services, and they are assigned to either in-person case management or telephonic case management. And that case management is provided through a variety of staff. So we have a multidisciplinary care team of public health nurses, social workers, mental health clinicians, substance abuse counselors, homeless service specialists, and community health workers that are able to serve this population. Patients are enrolled for 12 months of services. It's completely voluntary, and we have over 100 different case management staff. And case managers, it's really working on trying to address unmet social needs of patients. So patients begin in the program completing a comprehensive social needs assessment, identifying if the patient is in need of transportation services, housing, food, behavioral health, social services, and then it's a patient-centered care plan. So the case manager is working with that patient over their year of being enrolled to try to address those needs with the intention that that's going to improve their health status.
And a little bit more about kind of our underlying theory of change. What we think we're doing here with whole person care is basically we believe that that many of our patients, especially the ones who are addressed by this program, have a relationship between their physical health and their healthcare utilization that is suboptimal. Their physical health is worse than it could be, and that results in healthcare utilization that is both greater and kind of not the best kind of healthcare utilization that they could have. And our goal for the program is that when we deliver these services that address people's social needs, social determinants and other physical and other needs, that we shift people to a different relationship between their physical health and healthcare utilization, where their physical health hopefully improves and their healthcare utilization patterns change in such a way that kind of reinforce that positive change in their physical health. That's a little bit about what we're trying to do here. But our discussion today is really going to focus on how we have tried to use data across a number of different aspects of our program to improve our service delivery. The first one is, and we'll kind of go through each of these in detail after this, but the first is just in program administration. How do we enroll people into our program? How do we administer our program? The second is going to be looking into how we use data to improve our care and our services. And our final section will focus on how we're using this data to improve our planning for the program and also the evaluation of the effects of our program.
And I think I'll just jump in here real quick, Dan and Beth. I think one thing to say process-wise is that Marie is going to be monitoring the Q&A. And so if you have questions as you're listening, just please feel free to chat them in, and we'll be monitoring that. And so I thought before you dive into these areas, I thought I would just ask about kind of comprehensiveness of data. So you mentioned a great advantage that you have kind of being integrated, at least data-wise. And I'm wondering about, there's probably some organizations listening or representatives who may not be in that situation. I can think of examples of, say, an IPA who gets data for only a subset of the patients from a practice. So what would be your advice on approaching the use of data when you know that it's not the whole picture, it's not complete?
Yeah, thanks April. I think that, we definitely talked about how nice it is that we have this comprehensive data system, but it doesn't mean that we have all the information on everybody. I think that we're still in the same situation as just about every organization out there, where we have, some of the data that we'd like to have and some of it we don't have access to, depending on people's insurance status and where they're seeking care. We don't have all the information. So so it is something that we have, you know, a good amount of experience with, is, you know, of asking ourselves this question of what can we do with the data that we do have. I think, I guess, you know, kind of briefly, there's two things that I would say. The first is to try to identify a you know, maybe not a subset of the population, but a you know, some limited space that you can define in which you think you do have a complete picture, and see what you can see there. And then kind of, you know, if there's other parts of your population or other parts of your data where you don't, you know, you don't have a full picture, you can kind of compare that to what you see within the limited population, and that can give you some sort of idea of how different things are. I think with missing data, there's always just going to be an open question where, you know, it could be, it's hard to say, when you don't know the answer, it's hard to kind of make any sort of firm conclusion. But you can kind of get hints of it and use that to kind of to put the findings that you do have in context and present those findings with the questions kind of built in.
Yeah, thanks. That's really helpful. Marie, are there any questions coming through that we should?
No questions at this time, but there have been some folks who've said they've had a hard time hearing you, Beth and Dan. So if you could just speak up a little bit. I know the phone is as close as it can be, I think, to you.
Yeah, I'm hearing you guys loud and clear. I know I did actually right when I got on. I went down next to the audio option, and I clicked on audio settings, and I was able to turn up the volume to hear both of you. So that's maybe a little tip that people could try.
Thanks, April.
We moved the microphone a little closer too, so hopefully that's better.
Great, thank you.
Right, so first I'm going to talk about kind of how we use data for our program administration, kind of how we've used data integrated into our program design and our patient identification. So the way that the whole person care, how Community Connect works, is it is an administratively administered program, which is to say that we don't accept patients on a referral basis. We identify patients from the population and we enroll them into the program administratively, and then we reach out to them to let them know that there are these services that are available to them. And that differs from most case management services that we've seen out there. And so we really need to have a good data model and a system in place to be able to do this. I think it's been really beneficial because of the size of our program to rely, to try and fill roles of 12,700 people, purely off a referral basis is just not feasible. So we kind of really needed to have some sort of administrative way to enroll people into the program. And I'm going to talk a little bit about how we use our data to do that. So the first thing is we need to kind of identify the high-risk people in our population. And we start by creating a data warehouse. And that, what we do is we kind of pull information from as many different sources as we can. All the different sources that are linked together, we get information on people's medical history, their utilization both within our system and outside of our system with claims, their utilization of other specialty clinics like our homeless clinics, their utilization of mental health and substance abuse programs, and a number of other kind of systems across our county. And we put that all together into a data warehouse where it just allows us to link the system together and see what people's utilization history has been over time. And once we have kind of a historical record of what people have done in our county, we turn this into a risk model. Basically, we identify what we knew about people at a certain point in time. We can go forward in time and say, well, what were people's utilization patterns going forward, and then use that relationship to kind of predict who among our county right now is kind of at the highest risk of utilization. So overall, our goal is to identify future avoidable inpatient and ED visits. And by avoidable, there's several different kind of algorithms that we use, but the underlying idea is that, you know, some utilization could be prevented if people had different, you know, through better primary care or through better knowledge of how to navigate our health system. There are some ED and inpatient visits that could be avoided. So we really tried to target in on the type of person, the type of utilization that we thought whole person care could really do something about. So with that risk model and combined with our data warehouse, we're able to generate an eligible list. There's a list of high-risk patients each month as kind of new information comes in, as people's utilization patterns change. We identify the highest risk people in our population, and we also kind of need eligibility we need to know that the people are currently on Medi-Cal rolls, and you know, by incorporating kind of some of our different data sets, we're able to take a closer look at eligibility and kind of modify our list based off who we think is going to kind of benefit for our program and be able to be continuously engaged with our program. We do exclude patients who are already kind of in other case management programs. And there's a number of them kind of existing in our county, but this is kind of the largest. So we create this list of people who we think, first off, are at risk for the thing we're trying to prevent, but also are, you know, able to be, you know, kind of administratively engaged in our program, that they have the right kind of status from an eligibility perspective, that we're going to be able to serve them continuously for the year. So within that eligible list, we start to do enrollment. We identify the high risk cohort, and we enroll them into the program. So once we've identified our population, we kind of, since our capacity right now is 12,700 patients at any point, everyone's kind of voluntarily enrolled for a year, but there's always a continuous churn of people on and off the program. So at this point, we're generally enrolling about 1,000 people a month. And each one of those people then has to be linked with a case manager. We have a number of different case managers. We have a number of different specialties kind of based upon what sort of needs we anticipate our people might have. So for instance, we have mental health clinicians who specialize in working with patients with a history of mental health concerns. And so when we identify a person who we also know has been 5150'd or has had an emergency visit to our psychiatric emergency services in the last 13 months, then we preferentially link this person with a mental health clinician, and that ends up being their case manager. We do similar things for a number of our different kind of specialty managers. If someone has a substance use problem that's been documented, then we can link them with a substance use care coordinator. Or if they have a history of homelessness, then we can link them with the housing support specialist. So in this way, we kind of use our data to try to link each one of our potential patients with the case manager that we hope is going to do the best job of being able to address their most salient kind of issues. This is it's an imperfect process. There are certainly people who change case managers during time, and we once the case manager meets people, sometimes people kind of move up or move down or move over to different types of case managers depending on the case manager's ability to choose the right person. But in this way, I think we do the best job that we can kind of administratively of linking people together. And the fact that this is all done kind of with our computers, that we have this whole process automated, we've been able to save a lot of time. We estimate 347 public health nurse hours a month, or 2.5 to 3 FTEs of chart review and enrollment and eligibility determination that's kind of avoided by this process that we're using. And so I kind of described each one of the parts of our enrollment process in pieces, and that's certainly how each one is developed. Each one of those steps that I just mentioned has been individually developed and kind of put together by our team. And when they started, they were all really separate workflows. We had to kind of generate our data warehouse for the month, and we'd build a predictive model and feed those results back in. We would then randomize and enroll our people into our program, assign case managers, and then also do reaching out, which I didn't mention. We have to send a letter letting each person know that they've been enrolled, which is 1,000 letters a month can be an administrative burden. And so as we started doing this over several months, we realized that some of these things could be chained together. It was possible for us to build the data warehouse and then the predictive model kind of at the same time, and to assign case managers and then send letters out at the same time. And so kind of over time, as we kind of went through the process month after month, we learned to kind of chain some of these events together. And eventually, after about a year, we've been able to move towards full automation, which is to say we kind of press a button and the whole process kind of just runs. It's linked together with the scheduling program that kind of runs each process one after another. This really was a big effort. It took us several months of with dedicated development staff to kind of link the whole thing together. At this point, we've really been able to kind of reap the benefits of that. So what was, this process was generally taking Beth and I, among several other of our staff, a week or so to complete every month, where we were, basically just identifying and enrolling people. And that was, that was a lot of our time, was just making sure that we got that done. At this point now, it's probably about an hour of our time where we press the button and we make sure that the numbers are right, and we do a couple of basic checks. And so that's really just been a great time saving for us and for other members of our staff that have allowed us to focus on a lot of the other things that we're going to be talking about here. So it was a big effort, but we've definitely found automating things as much as possible be really worth the investment. The one kind of caution there is that when everything runs together, the system ends to be a little bit fragile. It's easy for things to break when there's not somebody looking at every single aspect of it. It's easy to kind of forget about little things, and when something is changed, the system has gotten quite complicated. So you do need to, while it's certainly a time saver, you do need to kind of think about it when you're making other changes, and kind of resist the urge to just kind of set it and forget it.
Great, thanks. So I have a question, but let's turn first to see if there's questions that have come in from participants. Marie?
Yeah, the first question is, can you share again the number of hours shaved by automating your process?
Sure. We've estimated it to be about 347 hours a month. So we took that calculation based off of, we serve about 25,000 people a year. And we just basically said, okay, let's say if someone was doing a full chart review and doing that enrollment, sending that letter out, we said very conservatively that would take about 10 minutes for someone to do. Actually, it could be quite a bit more time. So when you just do the math on that, that would be 347 hours a month.
Great, thanks. And can you just share a little bit more detail about the predictive model that you built, and kind of any challenges that you faced around automating that linking process that you can share with the group?
Sure. So the risk model, to address the first question, has, as I said, its outcome, the thing it's trying to predict is this avoidable utilization. We have a kind of a combination of avoidable ED utilization and avoidable inpatient utilization. And in terms of predictive, kind of variables that go into it, we have a number of, we have a bunch of different variables. There's, I think around 80 to 100 or something like that. But they're broadly kind of spread across 3 different categories. We have kind of our utilization category that just looks at what people, people's utilization history in both medical and non-medical services. Also kind of their personal history or medical history, what sort of diseases they've been diagnosed with, other kind of demographic information, and also kind of their social needs, as best as we can estimate people's social needs usually via indicators that they've interacted with some of our social care providers in the community. And I would say, briefly, one thing that we've definitely learned is that utilization was by far the most important. It was not surprising given that we're predicting utilization, but past history of utilization and utilization of other services, not necessarily exactly ED and inpatient, was by far the best predictor of which patients would be at higher risk.
Great, thanks. There's just one more question that I'll add in before we continue to move, or I'll give back to April to ask her question, which is, are you also tracking, just when you were describing the Community Connect in the program itself, there was a question that came in, are you tracking the impacts on the patients at the patient level for those that are enrolled in this program?
Absolutely, and we're going to talk a little bit more about that at the end later on in the presentation.
Great.
So my question was more about kind of the human side, I think, of what you've been talking about, because these results are so impressive, both the predictive modeling and how you were able to kind of remove so much waste from the system. But who did you need to engage across, such a large kind of organization in the county in order to do this effectively? And if there's any lessons you learned in that process?
Sure. I think, I think the 2 parties I would say is definitely leadership at the health system level. This is a non-traditional way of recruiting patients into a program, and I think there's definitely benefits and drawbacks to having an administrative process. So, and I'd say the second group is definitely the providers themselves. So, as part of, I guess, launching our program is that there was a number of roundtables and presentations that were done to providers, and I think, went through basically a standard presentation about the program, explained how we don't accept referrals, how we identify patients based on need, how we might be able to recruit patients into the program who never would have gotten in through a referral model because they aren't really in a setting in which a provider would have made a referral, and kind of go through all the benefits of our program. And then I'd say usually the first question people ask are, that's great, how do I get someone into the program? I have a great patient who would do great here. So I think it's definitely it's education on, continuing education on the model. And I think it's important to recognize that it's definitely not a perfect system. I think this was really done in such a way because we were able to essentially meet high levels of program enrollment, and then identify a population that may have never received services from a case management program. So it's definitely been some lessons learned, and I think some things that we may adapt in the future, but I think overall it's been a very effective system.
Great, super helpful. Okay, I'll let you guys continue. Thanks.
Okay. So the next part of our presentation is we're going to talk a little bit about how we've used data to improve quality at the point of care and create some sort of value-added services for our patients. So I think one of the first things I wanted to mention is we just have, as Dan mentioned, we have a lot of different data sources. And I'd say the first year was really spent kind of understanding what some of these data sources were and seeing what was really useful for case managers and patients. And I think the goal was how do we put this at the point of care for the case managers to kind of get information on what's really important so they could take action on it. And so in our second program year in 2018, we started looking at creating a front-facing dashboard for the case managers where they could basically get a snapshot of who their patients are and get indicators on what needed to be done with that patient, what kind of different services maybe hasn't the case manager completed yet, was the patient just released from the hospital, should that case manager follow up? Was there some sort of high-risk notification that that case manager could do? And so we spent a lot of time through a human-centered design process working with both case managers and managers on how to design a dashboard that was integrated into the electronic health record, which is where they do their case management, that could kind of help them direct their work, organize their work, and then take action on it. And I think this was one of the key lessons learned in our dashboard project, is that every part of this dashboard that you see is interactive in the sense that you can click on a number or a link and see a list of patients that need a specific issue to follow up on, and then you can jump right into the chart as you're working with that patient. So I think the important part is that the dashboard wasn't just a tool to measure patients or to measure like the work being done. It was really a way to improve the quality of care for the population that that case manager is serving. The second way that I think we've used data to improve care coordination is the way that we've used it to collaborate with different groups. So as we've mentioned, some of the deliverables of our whole person care program were to break down silos, both within county organizations, so between our medical system and our behavioral health system and our homeless department, and also those outside of our health network. So for instance, our human services agency, different CBOs. And so data's been a very powerful way that we've been able to do that. And I think as we started off doing that in ways that we've essentially shared lists with different partners and basically trying to figure out which patients do we share together. And I think when you're able to identify those mutual patients, I think it really does change the conversation from my patients to our patients and kind of facilitates that process of how do we work together. And I'd say as we started to have these conversations, it really started to then get into the depth of which ways are we duplicating services with each other, and then which ways can we coordinate with each other. So data's kind of set that foundation to identify duplication in services. And then, so for instance, there may be different case management programs within our health system. So because we've had this data system, we're able to identify patients who may be enrolled in both, and then being able to develop data systems to prevent double enrollment in two programs that may have similar sets of services, duplicative billing situations, et cetera. And then it's been able to look at places outside where maybe that there is a appropriateness for having two care team members together. How can we better coordinate with our patients? So I think one good example is with our homeless management information system, is that we were able to share data across to see which patients are in coordinated entry and which patients are members of our case management program. And by doing that, we've been able to actually create a broader integration of our data systems together, and that case managers can see within their own systems, oh, this person is also being managed by a case manager at the shelters, or this person is being, and that's showing up in the shelter data system, and patients in our health system are able to see this person's getting managed in that shelter. So I think it's been a very powerful way in that the contact of each case manager is being put on a joint care team in their own systems, and that's been able to facilitate how we can better serve the patients at their level with everyone who's involved in their care. Lastly, we started a project this year on how can we use this data to provide what we call kind of value-added services to our patients. So this idea really stemmed out from one of our community health worker case managers. She was in my office one day and we were running some reports, and she saw I had a report on the number of patients who had a housing need identified. And she said, I would love to have that report because I could quickly identify all those people. And I have this list of like a new housing list opens, and I could send it out to all of them at once. So it kind of really gave us the idea of how could we identify patients based off of needs that they have and kind of do some sort of bulk outreach to them at the administrative level to provide a higher level of service. So we started this ongoing quality improvement project in which we identify different social needs that the patient will have based off of their own disclosure during their social needs screening. And if something like there's a job fair opening or job fair occurring, we can send out a message to everyone in that, few cities surrounding that job fair who has an employment goal open, an email and a message to the electronic health record portal, a piece of mail, a flyer on that, and actually have it look like it's coming directly from the case manager themselves. And so it could provide that linkage back to the system. We've done this through a number of social needs. We've also worked with the collaboration with our Human Services Department to be doing this for when patients are up for their Medi-Cal renewal. So we're able to send patients a notification of, hey, your Medi-Cal's up in a month. Remember to turn in your paperwork. I'm your case manager. I can help you with that. And we're able to do this on the population level. And I think what we've really seen with these projects is a high level of engagement with the patients. So for a lot of our messages, for our electronic messages, we're seeing open rates of over 40%. So I think if anyone who knows email marketing, you'd say that this is a pretty phenomenal open rate. We've seen instances of people getting re-engaged in case management services who may have fallen off. And we really see it as a way that's complementary to case management. So a lot of our case managers, especially our telephonic staff, have very high caseloads. And this has been a way for them to get relevant information into the hands of their patients on a timely basis, and it's basically taking the work to the central level. So I think it's a real best practice of our program and one that we're looking to expand within our program and also within the wider health system.
So thanks so much. I'm going to jump in with a question. So everything you've just described, Beth, is really what brings to mind for me is just putting the patient in the center and being, thoughtful about kind of what their needs are. And I'm curious about whether any of the data that you collect is actually patient-facing and shared with them. And if so, how did that go?
Sure. So I think we do get a lot of different data sources that we're able to, put back in the patient's hand in a useful fashion. So I'd say sometimes things go well, and sometimes I'd say might cause people to scratch their heads. So let me just give a little example of what I mean. So one place of data sharing that we've been able to coordinate is our Medi-Cal renewal. So that's one way in which the health system may have a better address or phone number for that patient than the Human Services Agency. So we've been able to actually push that out to patients and get them back, on the Medi-Cal rolls because they have correct information that they might not have had. I'd say an area where it's actually maybe resulted in a little bit of confusion for patients is how we contact patients after they may have been discharged from the emergency room. And sometimes we're getting that data from people within Contra Costa Health Services, and we're also getting that data from claims. So that could be someone being seen at one of the outside hospitals in the area. And so it can be confusing for patients to receive a phone call from a case manager on, oh, we hear you were just discharged from the hospital, how's everything going? When that's coming from a different health system in which their case manager is employed, and sometimes people ask those questions of, oh, how did you get this information? I relate to you as my case manager, not someone from the health system. So I think it really kind of opens up that question about what does it mean when you sign your HIPAA form in terms of care coordination and sharing data, and kind of who sees what. And I think it's kind of opened up some doors in that way of how we can talk about what that means with.
Great, thanks. Marie, why don't we turn to the Q&A? I think it looks like there might be some questions there.
Yeah, there was one question that came in around your case managers. Can you share a little bit about the kind of caseload that they have and how that varies from member need to type of intervention?
Sure. So we have two different levels of case management. So about half of our patients receive an in-person case manager. So this can be from a variety of professional staff. So we have public health nurses, mental health clinicians, substance use counselors, homeless service specialists, and social workers. And like Dan said, patients are matched to their case manager based off of some indicator within the data warehouse. Each case manager holds a caseload in the field of 90 clients. So patients are usually getting contacted approximately once a month, sometimes more frequently depending on that patient's need. And the case manager goes out in the field and has that home visit either at their house, they might meet them at the health center, sometimes at a McDonald's or Starbucks, with a library. So it's really meant to be community-based services. The other half of our population receives telephonic services through our community health worker program. So their caseload fluctuates between 250 to 350 clients. So usually clients are getting a phone call every about 2 months. So each case manager still does the same initial intake and social needs screening, which looks at a variety of issues in that patient's life, seeing what those needs are, and kind of creating a patient-centered care plan. And then we have identified about 20 different core services that the case managers do, anything from referrals and linkages to CBOs, to we provide cell phones to patients. We have a contract with a legal aid service, so we can provide free legal advice and services and representation in court. We have a supplemental housing fund that can provide transitional support in housing. So we have I'd say a wide menu of services that the case managers can access based on what that specific need is of the patient.
Great, thanks. And I'll just go with one more question before we move on. With someone here from pediatrics, and the question is, have you gotten any feedback on patient experience for coding for SDOH with ICD-10? They experience in pediatrics some concern for coding for social determinants of health on a child's chart, because parents are mostly the ones reporting. So just any feedback on that for this particular participant?
Yeah, that's a good question. So we currently aren't using ICD-10 codes and adding to the patient's problem list in our health system. We are identifying needs through a social needs screening, and we're basically flagging these in the patient's chart. But as a health system, we haven't yet come to a standardized documentation across our different case management programs. That's going to be a project of this year and next year, and that our health system's investing in I'd say universal case management program platform that's going to be used across all different case management programs, whether you come to ours within whole person care or within the health plan. And so I think that's really going to be the driving force to consolidating our documentation. And whether or not we'll be using ICD-10 codes, I can't answer that. But I think we will be kind of working to a more universal screening across programs.
Great, thanks.
Okay, I will continue on. So as we kind of wrap up, we're going to talk a little bit about how we've used data for program planning and design. So I think as we started our program, one of the big things that we've done is because we've had all this information, we've really been able to kind of do a deep delve into who are the patients we're serving and understanding what characteristics people have based off of demographics, based off of utilization patterns, based off of different systems that patients may be using. And it's kind of led to those questions of how do we plan services to best meet those patients' needs. And I think one of the areas specifically that it's been very instrumental in designing a training program for staff that are able to understand those complex needs. So all of our staff are trained in trauma-informed care, implicit bias, motivational interviewing. And I think having that kind of broad picture of understanding the population has really informed kind of our ongoing trainings and making sure people have those specialized trainings to understand, who are the populations that we serve. I think it's also kind of dispels some maybe common myths that people have about a population that's high utilizing. So I think many people thought that this population would be older and I'd say have more chronic diseases than they do. So not to say that this population doesn't have a lot of chronic disease, but I'd say it is a much younger population than many had anticipated. So I think our average age is 42 years of age. And so it's definitely created, I think, an awareness of what does it mean to be doing outreach to a much younger population, and how do we maybe design outreach in a different way. So use of texting is maybe done a lot more by case managers than they would with the different populations. So I think it's definitely allowed to kind of create specialized program delivery. And lastly, I just wanted to mention that as our partnerships have increased, it's really, it's kind of begs the question of how do we make definitions around these different characteristics. So I think homeless is probably our best example in that there are a lot of different definitions of homeless, whether you're talking about HUD definition, Health and Human Services definition, and I think it's really required us to understand what are the different definitions of homeless. How do we want to define that internally? Are there different indicators that we have within our chart or from the different systems people use so we can better identify patients and then create different interventions and assignments for those patients? Lastly, I just want to talk a little bit about how we've used data for our operational decision making. So when we look at all the myriad of different projects and needs, nearly every single project that comes across the table is important and could be argued that it's worthy of tackling. And I think the way that we've had access to data has really helped us understand the scope of the problems. Is this impacting a large number of our patients, a small number, and helps us as a program to set priorities and allocate resources appropriately. I think it's required increasing the data literacy of our managers across all levels about how to use data in ways so that they can help make their decisions on operationalizing things. And it's required us to be able to present data in a digestible way and on a timely fashion.
Okay, so I'm going to move on and talk a little bit about how we're using data for evaluation and how we're trying to use that evaluation to guide our policy. So I think one important thing to remember about whole person care is that it's a really diverse program. We're offering a lot of different services to our enrollees. Beyond just case management, there's also referrals to community service providers. We help them with their eligibility for Medi-Cal and enrollment and other types of public benefit. We also can offer them cell phones or legal aid. If there's a housing fund, we generally just kind of educate them about our health system. So each one of these programs is offered to some of our patients. Not every patient gets, not any patient gets every single one of these, and each patient gets a kind of a different suite of services depending upon their needs and kind of what's available right then. So what we really want to do when we come back to our decision makers is have some sort of way to say something about this program as a whole, which is hard given that there's so many different aspects to the program, and it is kind of it's not universally applied to each different person. And so what we've been trying to use data to do is to develop some sort of way where we can address this question kind of as best as we can. So the way that we kind of decide to structure our enrollment is basically around a randomized control trial. When I was speaking earlier about our enrollment process, we identify kind of high-risk people in our population, and what we actually do is we take that group of high-risk potential enrollees and we randomize them, and so within each group, people are either enrolled or identified as controls. And so in this way, we have kind of a group of people who are available, who are matched with our enrollees, and they give us an idea of what would have happened to our enrollees had they not been enrolled. And in that way, that allows us to compare them along a number of different axes, not just kind of one specific axis, but all the different outcomes that we're trying to make an impact on. Each one we can kind of look at, and we have this control population that allows us to make that comparison. So yeah, our overall goal is to try and do this, simultaneously in some respect. We can look at all the different outcomes simultaneously, and we don't necessarily have to design our program evaluation with only one outcome in mind. So the way that we kind of ended up having to do this is we ended up kind of building a new evaluation data warehouse. For this data warehouse, the center of the data warehouse is the enrollment. And by enrollment, I mean not only someone being enrolled, but also someone being identified as a control. And then for every single enrollment, we've kind of created a number of different tables and pieces of information that fall under a number of different categories. First, we kind of have basic patient level information that tells us about what happened to each patient each month, and information about their disease state, whether or not they've been diagnosed with new diseases or things like that. And that's kind of basic information about the patients themselves. And we also have a number of internal metrics that allow us to measure engagement with the program. Did somebody were they reached out to by their case manager? Did they finish their kind of screening? How often were they contacted? Were there specific goals that were identified for the patient? And finally, we kind of have these external measures. For example, ED visits or inpatient admits. Every single one of those is stored in another table, and each of those can be linked back to the enrollment. So they're linked back to the enrollments or the control periods of time when someone is identified as a control. So this has been really helpful. I think one lesson that we learned in doing it was that this is also a very large project. We've spent a lot of time working on it, and it's taken kind of much longer than we hoped. We expect it to be, we definitely expect it to be worth it at the end, but this right now, what I'm talking about, this is kind of a work in progress as we are still in the midst of building this evaluation warehouse. I think once we have it completed, we'll be able to compare enrollees versus controls on a number of different measures, but the process of building it and identifying it and linking all the different databases together to create this new warehouse has been quite substantial. So we then tried to use this basically to inform our policy decisions. What we're trying to do with our evaluation warehouse is to ask a similar question in the same way. We can kind of use the same code, the same queries to address the effect of our program on a number of different outcomes. And once we've done that, we can kind of tie each one of our outcomes with a specific dollar amount. We say if you avoided one ED visit, we estimate that is worth this much in savings, and one extra primary care visit is worth this much. And so for each one of these kind of events that we're looking at our outcome, we can kind of tie it with a specific dollar amount. And then, so for as many of these measures that we're looking at as possible, we can kind of combine them all together and measure them on the same scale and get some sort of global estimate of the return on investment of our program that accounts for, as many of the different, potential impact of our program as possible. So yeah, we're really hoping that by standardizing the way that we're approaching asking questions, and by using a common metric, the metric of dollars, we can combine the really disparate impacts of our program into one sort of final number that can give our policy decision makers the right answer to make the decision about who and how this program should go forward.
So I'd say to conclude our presentation, just wanted to kind of talk about it with some lessons learned, and that we kind of pinpoint 4, and I'm sure we could list about 14 or 40, but I'd say these are kind of the big ones. I think that upfront investments have really yielded great dividends in terms of, Dan talked about the risk model. We've talked about setting up our population health module, our dashboard. These are large investments that take a lot of time to do. And I think that, you know, we've probably underestimated the initial investment in those areas. And I think the one point I wanted to make is that these are not static or one-time investments. I think a lot of times we think of technology as oh, we're going to build it and then we're going to be done. And I think that as people get used to technology, you know, there's obviously the ongoing maintenance of that, but then there's the ongoing tweaking of it. And that as people get used and comfortable with technology, everyone always wants to make it better and better. And, oh, wouldn't it be cool if we could put X, Y, Z in our dashboard? And so I think making sure to build that into your time schedule and your funding mechanism is very important. Secondly, just knowing that audience for when we're presenting data is very important. What type of material should we be presenting? What level of technicality? And most importantly, what's the time frame? When do people want to see data? And how frequently? I think is a lesson that we've been learning, and kind of how quickly to sparse it out has been important. You know, questions around data, like I said, data questions always yield more data questions. So it's really important to build that flexible framework like Dan was talking about, so you can make changes and adaptations. With every evaluation answer that we'll be giving over the next few months, we know that there are going to be 7 questions for every one question. So how do we kind of create that, think about that up front and creating that framework so it can be adaptable, so we can answer those kind of deeper delve questions. And then lastly, I just want to talk about that data projects are really important collaboration between the IT department, your quality improvement department, and program staff across all levels. And I think having everyone understand the different work that people do is extremely important, and knowing how to work well together, I think is a real recipe for success. That these data builds are not quick builds. It's sometimes people say, oh, maybe you just put a button there. And I think educating about what that really means, and then having similarly the IT department understand, like, oh, well, it's only 7 people. Well, that may be a really important 7 people to that case manager. So I think understanding and respecting each other's work is very important, and to have those spaces to do that at different meetings is essential to kind of build into your design of programs.
Thanks. That's terrific. So we just have a few minutes left. I'm going to ask Marie to go ahead and turn to the question queue and pull out some. I imagine we probably won't have time to get to all of them, though.
Yeah, so I have, I'll go with 2 questions. One was asked by a few people, and I think would be a quick answer, which is, what social needs screening tool do you all use?
Sure, great question. So we designed our own screening tool. We started using a screening tool developed by Health Leads because that was the resource database we used, and quickly upon using it, our case managers gave significant feedback that they needed more information and more details. So we had a very extensive process through an internal quality improvement project that we called the Social Think Tank, where case managers came over a series of months, and we basically delved into one domain at a time and talked about what question would you most like to see about housing, what's the best order, and essentially developed our own social needs screening tool. It's very long, it's 42 questions in length. We ask a number of things about social support, really try to use motivational interviewing as a technique. I think the one key thing I would say about the screening is that it's not meant to measure. You know, there's no score at the end. I know several screening tools have a score. This tool is really meant to be done in person or over the phone using a motivational interviewing technique to kind of get the person talking and start developing their own care plan. So sometimes it's done over 2 sessions, 3 sessions, but it is kind of meant to be that conversation starter. We've had very good success with it. And like I said, we've probably administered over 12,000 screenings to this point.
Great. And then the second question, you talked a little bit about this, so if you could just expand a little bit more, which is how are you able to share and collect information from patients across your providers with patient consent or BAA, or how are you doing that? If you could just share a little bit more about that.
Sure. So within Contra Costa Health Services, we have a universal consent form. So if somebody, our health system operates the hospitals, the clinics, the public health, school-based clinics, healthcare for the homeless, detention health. So because there is one universal consent that crosses all those departments, we're able to share within that. Additionally, we've created some MOUs with different outside organizations with consent to share, one of those being our Human Services Department. It took us 2 years to get that consent signed, and ultimately we ended up getting that signed because of language inside of our own Contra Costa Health Services consent to serve that says that we're able to share information with our Human Services Department for care coordination. So I think those questions of patient consent are very complicated. It takes a large team with a lot of legal knowledge and a lot of collaborative work and understanding what your common goals are to get those signed. But those discussions can't start early enough. I'll just add there, after that MOU is signed, there's the whole process then of how do you operationalize that data. I think in a lot of ways, sometimes you're dealing with two organizations that aren't speaking the same language in terms of how their data is stored and what that data is. And so, someone at a health system, how do you explain to someone in a human services, they're like, oh, I just want every visit. Okay, well, what does that mean to someone at human services? Similarly, if we just say, we want every benefit the person's been in, okay, well, what does that mean? So I think understanding those common languages and being real education, having the different IT departments get some education on how to kind of meet the MOU in the theory that it was meant to be, and kind of understanding what that is a lot harder than maybe people anticipate.
Great. Well, thank you both so much, Beth and Dan, for sharing for a second time the work that you all are doing at Contra Costa Health Services. And April, thank you so much for facilitating the discussion. I just popped up a poll on all of our participants' screen. If you could just take a minute to take the poll, it helps us better understand how we can provide content that supports your quality improvement efforts. So again, this is the 5th and final webinar in this series. This webinar was recorded, and we'll be sharing that recording with all registrants in the coming weeks. It will also be posted on our website. Please go and visit our website at www.chcf.org/CIN, where you can access all the recordings in this webinar series. So thanks so much, everybody, and have a great rest of your day.
Thanks, everyone.
Thank
Thank you.